So, good afternoon, ladies and gentlemen. We are ready to start with our next program, next webinar, which is being organized by the PCOS Society of India in collaboration with Monash University. Now, this program is interested in taking forward the guidelines which have been developed by Monash University in association with many other organizations. And I'm happy to let you know that the PCOS Society was one of the societies out of the 37 which were included to be part of the development of these guidelines. So this is something which we have been doing, and we have completed at least 8 studies. This is our 8th program, and we are going to be talking about the. So this is, I'm sorry. Before that, this is the presentation of the evidence-based guideline, which has been released in 2018, and this has been co-authored by ASRM, ESHRE, Monash University, and CRA PCOS. These guidelines have been published in 2018 in both fertile sterile and in human reproduction. So today we'll be discussing about gonadotropins, which have been used by all of us for induction of ovulation in women who do not respond to clomiphene citrate or to letrozole, or who do not get pregnant with the use of these oral ovulation-inducing drugs. Gonadotropins, we have been knowing that since more than 50 years they've been developed, and they started first with the use of menopausal urine to extract HMG from it, which was used as an ovulation-inducing agent. But over the years, it was found that it could cause issues with causing some kind of infections with the use of human products, and therefore, gradually, this human menopausal gonadotropin was gradually sort of more and more purified with the removal of the LH from it, with removal of any proteins from it, so that we could use it subcutaneously earlier. Previously, when you used it as an initial product, it was always intramuscular, but with the use of highly purified product, we could use it subcutaneously. But when it was found about 20 years ago that it could cause some kind of infections because of the use of human products, recombinant FSH was developed, which is highly purified and synthesized in the laboratory. And similarly, we have LH recombinant available to us, and these are not human products, and therefore have been used extensively all over the world. Now, these products can be used in different ways, and as I mentioned to you, the highly purified one is the one where most of the protein has been removed, and therefore it's relatively purified and does not cause allergic reactions. Also can be subcutaneously. While the recombinant FSH and LH can be used subcutaneously, and it becomes very convenient for patients to use it through a pen. So these are the gonadotropins which are available. In India, we use a lot of HMG still available, and we use it, whilst in many other countries, urinary gonadotropins are not yet available, not any longer available. We know that there is a whole protocol in place for treating PCO women for ovulation induction, and there are various sort of suggestions. Of course, the most important being weight loss, and of course the ovulation-inducing drugs become like clomiphene citrate and letrozole become the first-line therapy, gonadotropins being the second-line therapy for ovulation induction. And today we have with us Professor Claire Boothred, who is, we can show Claire, wherein we would like to invite her to speak to us on the subject of gonadotropins, which she has happily agreed to do. And it's my proud privilege to introduce Claire to you. And Claire has been with us at the Aspire. She's the Vice President currently at the Asia Pacific Organization of Infertility, and she's the current Vice President, and she's very, very happily agreed to speak to us on this subject. So, Claire, I will hand over to you. And she's talking to us today from Australia. What's the time there, Claire, just now?
About 6:30 in the evening.
Oh, 6:30 in the evening. So Claire is working hard for us, staying back.
I'm very grateful to you for giving up your working day. So thank you very much. Now let me just see how I'm going here.
So thank you so much, Claire, for being with us today. And I'd like you to start off with your talk, following which we will entertain questions which will come in from our audience. And this is to the audience that we would like you to type in your questions on in the section of the screen where they ask you to type in your questions, which will reach me, and I will forward those questions to Claire, and which she'll be happily answering. So over to you, Claire.
Thank you very much, Jura, and thank you very much for your kind invitation. Can you see my slides? Is that coming up?
No, I think you need to share your slides.
Share.
Have you shared your slides?
I thought I had. Hold on. Share screen. Here we go. Yes, it's coming. Okay, how's that?
Very good. We can see them now.
Okay. Is that the best view?
Yes, I can see.
You don't need to do a slideshow.
Actually, there's a lot of stuff available. I think go into the slideshow, it would be better.
Go to slideshow. I can do that. Okay, that's great. Listen, thank you very much. I don't know if you there are out there, but I think knowing India, there's probably a lot of you. So I thank you very much for giving up your working time. And I do hope you find this useful. And I do hope that there's some opportunity for interaction, because I think there are many different ways to do this. And we all work in different environments with different patients and different facilities. So I do look forward to an interaction, and hopefully we can all learn from each other. I'd also, I better start with my duality slide, and that is that I am involved with some of the pharmaceutical companies, and I am on a number of boards, and I also own a unit which offers fertility treatments. I don't think any of these are of great consequence because the evidence doesn't support one preparation over another. So I think as clinicians, we can actually choose whichever preparation we wish to. Dura has asked me to talk about the guidelines, and I am going to spend a bit of time at the beginning, and then I'm going to talk about this schema, that the definition of suitable patients, the preparation of the patients, the starting dose, the follow-up intervals, the cancellation criteria, and the development of an information sheet and consent form. I think the guidelines are a really very useful document. To bring that evidence together for us is very good. But you'll see when I take you through the small section of the guidelines on gonadotropins that there is way much more that we need to know as clinicians. And I think that's the delicious aspect of clinical medicine and the art of medicine, which we can still use the guidelines to help us, but really they don't actually tell us a great deal. So here, this is the justification, and I don't know if I can I move this thing out of the way? Yes, I can. Okay, here we go. So gonadotropin therapy is suitable for improving infertility in women with PCOS in specialist care with close monitoring. And I think, you know, if they've had underlining in the guidelines, that would be the bit that was underlined. Gonadotropin therapy provides better per cycle and cumulative pregnancy and live birth rates compared with the use of the oral anti-estrogens and or no therapy in anovulatory women with PCOS. So what that means is that FSH is better than clomiphene, and it is, but you'll see that we actually compromise ease of use and expense, so that many of the times we still use oral agents. Importantly, there is no evidence of teratogenicity, and it is important to note that gonadotropin therapy requires daily injections and the need for intensive monitoring with ultrasound. It has a risk of multiple pregnancy and has increased cost of medication compared with oral agents. So I think that's really important, and of course that's a beautiful justification. Lots of great minds have gone into the writing of that. This is just to remind us all about the grade criteria that we have, the conditional or strong recommendation, and the confidence level. The little plus signs indicate the confidence that the guidelines committee had for making a recommendation. And there actually, I think, 5 recommendations for this, and 2 good clinical practice points. So I'm just going to take you through those before I share my experience and the way I do things. Firstly, that gonadotropins could be used as second-line pharmacological agents in women with PCOS who have failed first-line oral ovulation induction therapy and are anovulatory and infertile with no other infertility factors. And I think that's the first point, and you can see that that's actually a conditional recommendation that's moderate, and but it's only it's not a strong recommendation. There's only 2 strong recommendations in all of these recommendations, and one of them I do think is a little tricky, so I will spend a bit more time with that. This is the second one. Gonadotropins could be considered as first-line treatment in the presence of ultrasound monitoring following counselling on cost and potential risk of multiple pregnancy in women with PCOS with anovulatory infertility and no other infertility factors. And that's really based on the fact that it's an efficacious intervention, but it does have some negatives, which is why there are some caveats in that statement. The third one is that gonadotropins, and this is a strongly recommended and a strong recommendation, gonadotropins, where available and affordable, should be used in preference to clomiphene citrate combined with metformin for ovulation induction in women with PCOS with anovulatory infertility, clomiphene citrate resistance, and no other infertility factors to improve ovulation, pregnancy, and live birth rates. Now, I just want to unpack the background to this statement a bit because I find this a little bit tricky. Even in a high-resource setting, I would still be using clomiphene and metformin, which would mean that where they are still available and affordable within our high resource setting in Australia, they're subsidised, but I still think that they have a place. This is based on a meta-analysis of 3 randomised controlled trials, and it was on 160 patients were in each arm, and that the difference in the pregnancy rate between clomiphene and metformin SH was 16% for the pregnancy rate versus 23%. So gonadotropins are more effective, but you could make an argument that for convenience and cost, it's not unreasonable to continue to use clomiphene and metformin. And I think in some ways I would have preferred the guideline to read something like this, that the available evidence suggests that gonadotropins are more effective than clomiphene and metformin, but in women with PCOS, blah, 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 but patient choice may mitigate that clomiphene and metformin will still result in pregnancies being conceived, and it may be that patients are prepared to forego some of the increased efficacy for lesser price and convenience. And I think that that's really a clinical practice point that I would say probably differs from the guidelines, at least for me. We may have some questions about that later. The fourth one is that gonadotropins with the addition of metformin should be used rather than gonadotropin alone in women with PCOS and anovulatory infertility, clomiphene citrate resistance, and no other infertility factors to improve ovulation, pregnancy rate, and live birth rates. And I will talk a little bit more about metformin later on. This is because the available evidence suggests that the pregnancy rate is higher, OHSS is higher. Miscarriage is not changed, but it is actually, so there is some evidence to support this. Here's the second strong recommendation, that either gonadotropins or laparoscopic ovarian surgery could be used in women with PCOS with anovulatory infertility, clomiphene citrate resistance, and no other infertility factors, following counselling on benefits and risks of each therapy. Now, this is based on Cindy Farquhar's meta-analysis that, in fact, using ovarian drilling is equal in pregnancy and live birth rates to 6 months of FSH, with a marked reduction in twinning. In fact, there's no twinning in laparoscopic ovarian drilling. So, in fact, it's a very good intervention to reduce twinning. So that's a very reasonable, I think, statement to have a strong recommendation. And I think that's a very useful thing, and I will take you through that again. Now, the sixth, these are clinical practice points now, so there's only really 5 recommendations in this area. And the clinical practice point is that where gonadotropins are prescribed, the considerations include cost and availability, which I've already alluded to. The expertise is required for use in ovulation induction, and it would be my hope and dream that we would all be experts at the end of this session. There is a degree of intensive ultrasound monitoring, and I'll talk more about that. There is a lack of difference in clinical efficacy of the available gonadotropin preparations, that we basically can use whatever you want, depending within limits on the circumstances. And low-dose gonadotropin protocols optimise monofollicular development, which is, of course, the goal with ovulation induction. But there are risks, and I will talk more about the multiple pregnancy and how I manage that in a moment. The second clinical practice point is that gonadotropin, and I think this is a very important one, that gonadotropin-induced ovulation is only triggered when there are fewer than 3 mature follicles, and the cycle needs to be cancelled if there are more than 2 mature follicles, and the patient is advised to avoid unprotected intercourse. So those are the guidelines. That's the framework on which our practice now hangs. I'm now going to take you through the schema that I outlined, and the first is defining suitable patients. And so this is my list, and I think you can debate these. I've set age. I'll take you through them in a moment. They could be debated, but greater than 20 years and less than 40 years. I think you could make an argument for saying less than 38, because I think most women with polycystic ovarian syndrome are ovulatory by their late 30s, and so ovulation induction has less of a place. And of course, we've got a new etiology to their infertility in that of oocyte aging, and you really don't necessarily want to have them having a less effective treatment than perhaps assisted reproductive technologies like IVF and so on. They need to have, and I think the third one is the partner needs to have a normal seminal fluid analysis, or at least a reasonable chance of conception with intrauterine insemination or coitus. So moderate and severe male factors probably are not suitable for ovulation induction. But a little bit more about that later. They obviously need to have at least 1 patent oviduct. Whether you insist on 2, I think depends on the individual circumstances. And again, I will talk about that and how we might manage that. There needs to be no suggestion of endometrial hyperplasia. And I think if there is an abnormal bleeding pattern which is suggestive of endometrial hyperplasia, that needs to be sorted out before FSH can be prescribed. And the couple need to be able to comply with the avoidance of coitus to avoid higher order multiples. And that's very important. And I usually meet with the couple to establish that. They need to also accept the risk of twinning from a social context, and also be medically suitable to have a twin pregnancy. So things like a fibroid uterus or a past loss of a twin pregnancy in the mid-trimester, or a unicornuate uterus, these might preclude FSH ovulation induction because of an unacceptable risk of twinning. They, in keeping with the guidelines, the ovulatory disturbance needs to be refractory to the conventional oral agents, And I also always offer them the alternative of laparoscopic ovarian drilling because of the equal efficacy to 6 months of FSH. Why do I say they need to be greater than 20? I think that you could debate it. It's possibly because this compliance with the avoidance of coitus is very important, and maybe that is a little less reliable in those who are less than 20, but you could argue that that's a politically incorrect statement. I have got some slides on my regimen of conventional oral agents, but I'm not going to go through it, but it is there for people if they wish to use it, because I think it is a very good menu that works and has worked, and 85% of couples will be pregnant with that oral regimen in 8 months of therapy, but it's not really clearly articulated in the guidelines, that practical way of using orals. But I'm now going to move to the preparation for the use of FSH. And I think the preliminary actions and investigations are that the partner needs to have a normal seminal fluid analysis, as I've mentioned, or a reasonable chance. And I meet the partner to discuss that, and that gives me the opportunity to ensure that he understands that if there are 4 eggs that are going to be romping down the tube, because of course women with polycystic ovarian syndrome don't necessarily need induction of ovulation. They may spontaneously ovulate in the setting of the FSH. So you could in fact have 5 or 6 oocytes, and this is where we do get higher order multiples, and that's why I say it's very important that they don't have intercourse in the 2 days prior to the ultrasound scan. And I will talk a little bit more about that later. They need to have the routine screening bloods for antenatal care, folic acid and iodine supplements, and depending on the context, the vitamin D supplements. Following the American College of Geneticists and ONG guidelines, we have to offer the carrier screen for selected autosomal recessive disorders and order that if the couple wish to do that. And I think they need to have a baseline pelvic ultrasound scan on day 2 to 4 of their cycle, or when they are quiet, and I'll define that later, to confirm that there is no ovarian cysts or tumours and that there is a normal uterus, and that's relevant to the risk of twinning, the evaluation of the risk of twinning. And I ensure that they understand the criteria for cancellation and the compliance in the presence of both partners, and I document that in the file. I also at this time consider the need for adjunctive treatment. In contrast to the guidelines, I don't use metformin all the time because some patients have had experience of metformin and find that it's a difficult drug for them to take. They have side effects. If they're able to take a low dose, but I don't necessarily expect them to have a lot of side effects, because not everybody can take 1,500 milligrams of metformin. And as I've mentioned, I also offer them laparoscopic ovarian drilling. Okay, so what's the starting dose? Well, it is always low. The Cochrane review indicates that it doesn't matter whether you use any of the preparations that Dura has so beautifully summarised at the beginning of this talk, whether you use urinary products, highly purified, or recombinant products. It doesn't actually matter. It doesn't make any difference. I do AMH to guide the start, so that if I've got a woman who's got a very high AMH, then I would be more keen to have her on metformin, and I would perhaps start at 25 international units, but a routine starter would be 50 for me. I also like to have a bit of an idea whether they've got LH hypersecretion. These are a sort of a sub-phenotype of polycystic ovarian syndrome, and these guys do very well with FSH, and it's usually 1 to 2 weeks into the FSH therapy that you start to see that the LH has started to fall, and that's a very good way of treating LH hypersecretion, in contrast to clomiphene, for instance, which tends to, if anything, exacerbate the LH hypersecretion. Economic considerations can be very, very important, and I appreciate that they often are in Asia. In Australia, we have a very kindly system for most of the FSH preparations, but not for the highly purified products. We don't have that approved for FSH, for ovulation induction, so that's actually quite an expensive thing for patients to use. And we also don't have the latest entrant to the market, the recombinant FSH, which is made in embryonic human stem cells, which is marketed in Australia as Recaval. That is not available for ovulation induction. So sometimes, and there isn't any evidence that Recaval is useful for this, but sometimes there is for menopause, and that becomes an economic consideration, and I'm sure it is for many of you for your patients. This is very important. The ease of use of the pen, and also the ability to adjust the dose reliably and to give a low dose of FSH. Some of the preparations, we have a bioidentical Bemfola, but it only comes single-use syringe, so it really doesn't have any place in ovulation induction. A pen that you can adjust the dose is more useful. How do I start it? Well, of course, many of these women are anovulatory or have severe oligo-ovulation, and they do not wish to wait for a period. Now, in the old days, I was certainly trained to administer medroxyprogesterone acetate or norethisterone to induce a menses. And of course, we now know that those progestins have an adverse carryover effect and the endometrium, or at least they do in IVF. And so I don't tend to do that anymore. I tend to do an ultrasound, a bedside ultrasound, and measurement of the LH and E2 and progesterone, the estradiol and progesterone, on the same day or the day before. And then if they're low, if the progesterone is not in the luteal range and the estradiol is low, and for my assay that's less than 300 picomoles per litre, and there are no follicles greater than 11 millimetres, I define that as being quiet. And women with polycystic ovarian syndrome spend a lot of their time in that kind of state, with a mid to low follicular estrogen and a low progesterone and no dominant follicles or no follicles over 12 millimetres in their ovaries. And so I can arbitrarily redefine that as being day one. Now, you might ask, do I worry about the endometrium on that arbitrary day one? Look, I don't, unless it's over 10 millimetres. It's often somewhere around 4, 6, maybe 8, and I don't worry about that. I just start the FSH. I start it that day under supervision. I teach them to do the pen myself. And then the next day they take the FSH at their preferred time, and they take it each day at that preferred time. Now, one of the questions that has been asked is, could we use this on second dailies, alternate days, because where patients are paying and it's expensive, it might be seen that that's a useful thing to do. But I don't think there's any evidence. And of course, the guidelines do say it's daily use. And I don't think there's any evidence yet for second daily use. But it's a good randomized controlled trial that maybe needs to be done, because maybe there is a need for that. So once they've started, either 25 or 50, then I scan them without bloods a week later. Again, it's a bedside scan. And at that time, I really expect to see no response. And I tell them that, so they're not disappointed. I expect to see nothing. What I'm really doing is to screen here for hyperresponse. Some of the ones who are exquisitely sensitive to FSH may have 20 follicles by a week of FSH. That's obviously a good time to cancel them. But that's what that purpose is. And very occasionally at 1 week, you do see a dominant follicle. If they don't have, most of them have nothing, I usually continue with the same dose and scan them 3 to 5 days later, depending on convenience. And I'm really looking to see when they get a dominant follicle, millimetres or more. And not all 12 millimetre follicles will remain as the dominant. They will sometimes come in and then regress, and you'll see another follicle come to be the dominant follicle. So 12 doesn't really commit, but as I say, they're interested in the game and they're very likely to progress. Once I do see a 12 or 14, then I continue on the same dose and I scan them according to convenience, estimating for a 2 millimetre growth per day. And I measure the estradiol, the LH and the progesterone once I'm planning to induce ovulation with HCG. I always do it on the day of that I induce ovulation, because it's a way of retrospectively reviewing the cycle and to improve the subsequent ones. And I'll talk a little bit more about that in a moment. I trigger according to convenience if I'm doing an IUI, or if the follicle is 16 to 22 millimeters in diameter. Obviously, one of the reasons for doing those bloods is to pick up an endogenous surge, an LH surge, because of course these women will be at risk of, may well ovulate themselves. I work on the premise that all follicles greater than or equal to 16 millimeter are fertilizable. So, and we'll talk about cycle cancellation in a moment. I measure the endometrial thickness. Now, if it's inappropriately thin, for example, 6 millimeters or less, when you've got a 16 or 20 millimeter follicle, then I would consider LH deficiency. I mean, it could be an endometrial problem if they've had past uterine surgery and so on. But if assuming they haven't had that, then that makes me consider LH deficiency. And I always check the LH. And the thing about that is that these are usually centrally based menstrual disturbances, but of course they're common, and so is lean polycystic ovarian syndrome. So that because the conditions can coexist, you've got to be looking for LH deficiency. And I think the hallmark of it is the thin endometrium or the inappropriately thin endometrium, often with a low estrogen as well. So you expect, so for instance, on my assay, I expect the follicle to have an estrogen of about 1,000 picomoles per litre. And if I don't see that, I say it's only 300 for one follicle, that makes me think a little that maybe there's LH deficiency. Not absolutely, because the estradiol assay is a capricious assay. It's not entirely reliable. Now, if I do think that there's an LH deficiency and that happens over a period of observations, then I would use a different gonadotropin, the highly purified urinary ones, which have some HCG activity, or in some countries we can add recombinant LH, Liveris, very expensive. In Australia, to use for ovulation induction, you've got to combine it with an intrauterine insemination to get funding for it. Or another way to deal with LH deficiency is to add clomiphene in the next cycle with the low-dose FSH, because clomiphene tends to raise the LH. Okay, so the next step is inducing ovulation. And I don't think it really matters according to the evidence what you use. It can be urinary HCG, 5,000 or 10,000, subcutaneously is acceptable, or recombinant HCG, which we have marketed as Overdrill in Australia, 250 micrograms. I still use the urinary products because they're a lot cheaper for patients, and the recombinant products is still a bit more expensive, so I don't tend to use it for ovulation induction, though they are available. If there's no endogenous surge, and this is based on no evidence whatsoever, I give them luteal support, and in a form of HCG, 1,500 IUs every 3 to 4 days after the day of ovulation. And I just think that gone all that time, taking FSH, being scanned, having blood tests, inducing ovulation, the last thing you really want is to have luteal insufficiency on the basis of that, though of course it does delay the diagnosis of pregnancy. I think intrauterine insemination can be done 24 to 36 hours after trigger. It doesn't really, it doesn't have to be military precision. And I cease FSH on the day of the trigger. And of course, the pregnancy testing is done 7 days after the last dose of HCG because of the half-life of HCG. So what are the cancellation criteria? These are very important with FSH because it's the way that you deal, that's the way that you avoid complications. As I said, follicles greater than or equal to 16 millimeters are deemed to be fertilizable. And if there are 4 fertilizable oocytes or follicles, they must cancel and avoid coitus. And so they understand that they're not allowed to have coitus for 2 days prior to the ultrasound scan. If there is possible fertilization of multiple follicles and the couple have had coitus, then I had, and I've very rarely had to do this, but I have had to do it. I've considered the use of a GnRH antagonist for a few days to block the release of the LH. And I've only had to do that a couple of times. It's a very rare thing, but it's useful to have it up your sleeve if you ever get yourself into a pickle, because you don't really want to have quadruplets and quintuplets. It's just not a good look. I think it's a value judgment about 3 fertilizable follicles, and I'll take you through why I think that. As you know, the guidelines say only 2. Now, and I think most of the women who are having ovulation induction, probably we should stick with 2 because they aren't ovulating, and so there's the sperm-egg interaction, or the opportunities for the sperm and the egg to meet are very low, and so therefore you have to regard them as potentially very fertile as a combination. And so 2 is very reasonable in those kind of cases. But you might say, the sperm isn't very good, or there's only 1 tube and there's 2 follicles on one side. And I think it's a value judgment, and I think it's not unreasonable to sit down and talk with the couple about how they would feel if they had triplets, because of course the medical evidence does support selective reduction to twins or singleton, and that's not acceptable to a lot of people and may not be available. So I think it's a very, but sometimes people have invested a lot and it's hard to cancel. So I think these are difficult things. So I've talked about that. And of course, if there's 2 follicles, then it's okay, because if twinning is not acceptable to the couple, then they really shouldn't be having FSH ovulation induction. They should be having laparoscopic ovarian drilling or some other method. So if they cancel because of a hyperresponse, 3 or 4 follicles, I always wait for a month, because I think the ovary needs to settle down from what is really non-physiological stimulation. And then when the ultrasound is quiet and the bloods are quiet, I start at the dose slightly lower than the dose which was being taken when the hyperresponse occurred. And I also consider adjunctive treatments for metformin and ovarian drilling, because of course you can do FSH after ovarian drilling and you're much less likely to get high as well. So those are the sort of things, a way of reducing a hyperresponse, if a repeat hyperresponse. How do I manage it if they ovulate and don't get pregnant? So you're very happy with the quality of ovulation. I look back at the cycle, see that the estradiol matched the number of follicles I expected, that there wasn't a premature surge, that the timing was good. How do I manage that? Well, I review, as I've said, I review the cycle, and then I confirm that the endometrium was adequate. I confirm that there was no early surge, and I start the next cycle on day 3 to 5 of their period at a dose at which the previous response was very slightly higher. And I think there's no evidence for that. It's some doctors do, some don't. I don't think there's any good trials on that. But because they've had physiological ovulation induction, 1 or 2 follicles, albeit induced by FSH, I think it's very reasonable to go on to a cycle immediately after that period that occurs. The key messages of an information sheet, I think, are, as I've discussed, the risk of twins, avoiding the risk of higher order multiples, the risk of OHSS, the chance of success, which is probably around 18 to 22%. It's actually a very good chance of success. The need for compliance. They can't take FSH out in the community and not adhere with attending scans and blood testing. And of course, the restriction on cut-or timing. So that's the end of my presentation, and I'm very delighted to take some questions. So I'll hand over to Dura now. Thank you very much.
Thank you so much for this excellent talk, Claire, and for the very, very practical suggestions which you put across. I think it will be very useful for our viewers to know how you also manage your patients. So there have been some questions coming in from the audience, and what we will start with, I would like to actually start a question with you, because you've covered a lot in ovulation induction with IUI cycles. We also need to sometimes go into an IVF cycle with PCO patients when they don't respond to when they don't get pregnant with an IUI cycle. But before we jump onto IVF, I have a question. We do get a lot of patients who come to us, they visited a few centers before, they come with thick files, whole lot of stuff done, and then, for years they've been taking treatment. And by the time they've come to you, they're at a little advanced reproductive age. So how would you handle those patients? Would you straight away start with gonadotropins? Would you straight away suggest IVF if they've already done a few cycles outside? How would you manage that?
Look, I don't think, I did say the age. I have a sort of I'm uneasy doing ovulation induction after 38 because I think those women are starting to run out of time. And if I'm going to do a less effective treatment than IVF, I don't want to do it for more than 1 or 2 cycles. I think this is a negotiated agreement, and I usually go through in detail how their cycles, how many cycles of clomiphene they had. Did they have a period after that? How many, was it ever combined with, have they had letrozole? Or have they had, have they had ever the use of dexamethasone? Are they very adverse to taking injections? And I think it depends on where they are in the journey. I never do these cycles for more than 2 cycles. So if I was doing orals, I only do 2 letrozole, then I move to clomiphene, 2 clomiphene, then 2 clomiphene and metformin, and then possibly 2 clomiphene and metformin and dexamethasone. And along the way, I'm re-evaluating the sperm because not all semen analyses are 100% accurate. And they're often, we end up finding that they've got male factor infertility, and that's one of the reasons why the ovulation induction didn't work. And I also consider the use of Lopiodol as they're going through that. So I think it is very reasonable to start with FSH if they want that and they've had a lot of experience and they're tired of using orals and they're getting demoralized by the lack of success. I do think, I often use the AMH to help decide where they are on the reproductive aging and their age also. So I think that's a tricky one, but I would always check the tubes for patency if they've had unsuccessful orals and you're embarking on FSH.
Then there are so many women, we are not really doing a laparoscopy for all our patients nowadays to look for any endometriosis. It may not be picked up on ultrasound, but you may have minimal endometriosis. So in such situations, would you still go in and do a laparoscopy and confirm whether there's endometriosis?
I think that, I think the advantages of laparoscopy are that, yes, you find out if there is peritoneal endometriosis. You also found out if there's adnexal adhesions, which may in fact be precluding collection of the fallopian, the adherence of the fimbriae around the ovulation, around the ovulatory follicle. And I think also it gives us an opportunity to instill Lopiodol. And so those are, so I think laparoscopy, and of course it has the opportunity for laparoscopic ovarian drilling. And of course you can revisit your ovulation induction regimens after laparoscopic ovarian drilling, that which isn't covered really in guidelines and the research, that we, if you've got a woman with very, very high AMH, 130, and their ovaries are absolutely stuffed full of follicles, they've got 40 antral follicles in each ovary. These girls do very well with laparoscopic ovarian drilling, and if they don't ovulate spontaneously after that, you can often revisit your failed ovulation induction. Now, these are obviously things that you would only offer to a young woman who's got plenty of time and has got normal semen and has got normal tubes. So I think that's some of the things that aren't captured in the guidelines, because that's the sophistication of dealing with a patient over a long period of time.
Yeah. Unfortunately, in our country, we find women having a poor ovarian reserve at a younger age, because women do get menopausal at the age of about 48 years mean in India. And I think in Australia it's 52, 53, age of menopause.
51.3, yeah.
So
that's very interesting. That's a very interesting finding, Dura. Do we have any idea why that might be?
I think it's ethnicity, because different ethnicities age at menopause at different ages. But definitely Asian population there is definitely a lower age at which they menopause. So women in India, actually, we tend to treat as advanced reproductive age at the age of 35 plus. Though I know that when we have women who are foreign nationals in our country, Caucasians, they easily, happily get pregnant even up to 40, 42, no problem. But Indian women, it's tough getting them pregnant after 40, 42, especially if you're just managing with routine treatment. We tend to have more of assisted reproduction in them rather than with just simple ovulation induction, especially if their age is much more than, beyond 38, 39, it becomes a bit difficult. So that's the ethnic.
I think it's difficult in Australia too over 40, Dura. If you look at our national data, it's they don't get pregnant anything like as much after 40. But yes, keep going. Sorry.
Yeah. So coming to the next question, there have been situations wherein we find that a woman has been given clomiphene citrate, the endometrium doesn't grow. In such situations, we used to tend to shift the patient to HMG to get a better endometrium. But nowadays, we have been using letrozole, and PCO women, we find that they give us better results. Do you have the same experience?
Do you know, I don't. I do wonder if I'm not using letrozole terribly well. I use it first because it's the available evidence is that it's first line. And one thing I do notice about it is that if you do how I talked about them, if they're anovulatory and you start when their bloods are quiet, they get bleeding very early. And immediately after the letrozole, I don't like that, so I induce a period with prometrium now for letrozole. I'm just not getting as much success. I just find clomiphene, it seems to work better, and clomiphene and metformin for the orals. But I have to accept that the evidence is the evidence. So therefore, letrozole is the first line agent, and I often wonder if I don't use it quite as well. I mean, I use. I think it's a 2.5 milligram tablet, and I think they use that for 5 days and then go up to a 5 milligram tablet if they in the second cycle. So I'd be interested in what you have found with letrozole.
Yeah, we use 5 milligram a day. With the 2.5, even we did not get good results, but with 5 we are getting better results. So I think we start with 5 directly. That's what I do. And I find that 2.5 doesn't really work well. I share that information with you, the same findings. But yes, when we switch over to the gonadotropins, we find that the endometrium grows much better as compared to...
Oh, it is. Absolutely.
Yeah. So now coming to gonadotropins, when we are using them, do you tend to combine metformin with for all your patients of PCOS, or do you try to identify which patients you will use metformin?
Look, it depends on their experience of metformin, because metformin is widely used in primary care in Australia. So many patients have already tried metformin, come to me, and some of them have had side effects. So if they're intolerant of metformin, then I think the ones that I definitely want to try with metformin are the ones who've got a very high AMH, who are exquisitely sensitive to FSH and are at risk of ovarian hyperstimulation. And I encourage them to take metformin as much as they can from the point of view of not having side effects of it. So yes, but I have to say I don't use it on everybody, but maybe I should, but I certainly do in a lot of cases.
So probably you pick up the obese ones, probably you use those who have got typical signs of insulin resistance, probably the ones with acanthosis, etc. I think they do pretty well with the metformin. That's what has been my personal experience. So coming to the other topic which we wanted to discuss is that, patients who have been given gonadotropins, plain gonadotropins, and you compare them to women who have been using clomiphene plus gonadotropins in order to reduce the amount of dose of gonadotropin you're using for a patient or to avoid hyperstimulation. What do you think? Does it make any difference in the results?
Yeah, look, I haven't done that a lot, and because I think I'm, have the luxury of having subsidised FSH, and the only time I've really found it to be particularly useful is in the combination of centrally based menstrual disturbance with LH deficiency and lean polycystic ovarian syndrome as well. But I can appreciate that there is a need to do that. And I actually don't think that there's likely to be any harm from that as long as it's monitored, just like a gonadotropin cycle. And you could probably run them on, say, 25 of FSH and 50 of clomiphene. And I'd be very interested to hear what your experience of that is. If, have you done that with good effect in the past?
Yes, actually for the IUI cycles, we prefer to combine the two so that we are using, especially in those women who really can't, come in for the monitoring, too much of monitoring. If you're using only gonadotropins, you really have to monitor them, especially in a PCO patient where, they suddenly would, create more number of eggs growing. So in an IUI cycle, yes, I prefer to use a combination so that I could reduce the amount of gonadotropins we are giving, especially in patients where I find that the endometrium is not growing well. For some reason, even in IVF patients we've seen, after we have frozen all their embryos, and then when you want to transfer the embryos back, for some reason, some patients' endometrium just doesn't grow on the oral estrogen therapy which we give them. And then we try with the transdermal estrogen. And the transdermal estrogen tends to work better than the oral estrogen. I don't know. What has been your experience on that?
Yeah, look, so you're using estradiol valerate for a frozen embryo transfer. Yeah. Yeah, look, I think it is certainly ethinyl estradiol in some women does not thicken the endometrium. And I don't know why. I think that's very interesting because, it should all be working through the estrogen receptor, but maybe there's some pre-handling of the ethinyl estradiol so that their estradiol levels, I just don't really understand that. With the Progonova, you do see that, and you see that, and these are often endometria that are adenomyotic, or they may have been scarred in the past. And I think there is also an individual susceptibility. And certainly, so, I do often use transdermal estrogen for frozens. I don't think it's necessarily something with PCOS. I think it's actually infertile population. And I think, the denudation of the endometrium to the basalis is a particularly difficult problem. It's not really Asherman syndrome because there isn't scarring across the cavity, but there is a denudation of the basalis. And these guys, whilst that's a bit outside this topic, they are very difficult patients to treat. And I think their pregnancies are complicated, and I think they have implantation problems, and I think they also are at risk of a retained placenta, and that sort of exacerbates that whole problem in their next cycle. They are difficult cases indeed.
Yeah. So you mentioned about ovarian drilling. Do you tend to drill, every time you do a laparoscopy, she's PCO, do you just go ahead and drill or do it in selected patients?
Yeah, I definitely select them, and I think the way laparoscopic ovarian drilling works is probably by the destruction of oocytes, because we know that women with PCOS start with a very high level of antral and preantral follicles, which is measurable through AMH, and as they age and the number of oocytes drops, they actually in their mid and late 30s start to ovulate because they don't have that whatever the effect of these large number of follicles in the ovary is in terms of impeding the development of dominant follicles or impeding recruitment, whatever it is, as they age, that problem becomes better. And I think that ovarian drilling works because it accelerates reproductive aging. And so these women get a lower AMH. So I don't do it routinely because I don't want to induce ovarian failure in someone by making the wrong diagnosis. And I actually also want them to be involved in the decision because, of course, there are periadnexal adhesions which can occur from ovarian drilling, even with the best of techniques. Look, I do ovarian drilling, and when I started doing it, it didn't seem to work. I realised that I was far too delicate with my level of injury, and so actually, Marquardt has published on this, and her technique from memory is to apply, I think, 6 applications below the capsule, because you want to reduce the risk of scarring and adhesions to the ovary, but 6 to 8 burns of 100 watts. I think it is, and for 10 seconds, which is a really long time. It's absolutely traumatic. You know, I found, and that's why I'm sure my ovarian drilling, when I started my career as, or when I was a young CREI or a young subspecialist, didn't work, because I really didn't give that kind of level of injury to the ovary. But I frequently do unilateral PCO, laparoscopic ovarian drilling, rather than bilateral, because you therefore, you know, if there is going to be any risk of scarring, you've only got it on one side. And if I've, you know, if you, so that, yes, but I do think laparoscopic ovarian drilling is a very effective treatment according to the evidence and in clinical practice. But I do involve the patients in the decision, so they need to understand the negatives of it. And also, I think it takes about 4 months for it to work. And so I expect them to be getting pregnant 4 months after the drilling.
Yeah. So you have any any data which you would have of your own to compare just simple gonadotropins versus post-laparoscopic drilling?
No, I haven't done any randomized controlled trials. I think the data is fairly tight on that one. That's a very nice meta-analysis in the Cochrane, which is very convincing, I think. They're not always convincing, but that one is.
That is convincing enough, that's true. Okay. So the other question which has come in is that those women who are on, what precautions do you take to prevent ovarian hyperstimulation in these?
Yes, that's a good question. Look, I have published on this one. We did some guidelines in the CREI group. There's a number of interventions. I mean, with ovarian ovulation induction, you're really using low dose. And I have seen ovarian hyperstimulation in a lady who had FSH ovulation induction. She had a singleton pregnancy. I think she had 1 or 2 follicles, but she had very mild OHSS, but she definitely had ascites with her pregnancy, because of course it's pregnancy-related OH. Very common, and it's not very severe. But how do you reduce it? Well, metformin is a way of reducing it, and I think also using a low dose. And obviously cancelling and avoiding LH and HCG if they have got a lot of follicles. Now in IVF, that's a very different ball game. Metformin definitely has to be on board, so I always use it if they've got PCOS and I'm doing IVF, if I can. And using antagonist is associated with a reduction, so not down-regulating with a GnRH agonist. So using an antagonist protocol. And then, of course, you can use an agonist trigger if you get a lot of follicles. I combine that with a freeze-all strategy. I'm not one who likes to use, I have done very occasionally the administration in low dose in the luteal phase after an agonist trigger, but most of the time I do a freeze-all, because you really want to prevent pregnancy-related OHSS, because that is the more severe one. The trigger-related OHSS will always go away, and it's short duration. It's not usually, doesn't usually get you into a lot of trouble. The other thing that I do use after the event is cabergoline, and I use that for about 4 to 5 days after the egg collection, if I'm really worried if we've got 25 to egg oocytes, and I've done an agonist trigger, because an agonist trigger does reduce it greatly, but it doesn't reduce it to zero. And there's quite a few reports in the literature, and I think George Gressinger reported on a series that had quite a few cases of OHSS even after an agonist trigger. So those are the sort of things that I tend to do.
Yeah, that's what I think most of us do. But is there any criteria you look for in a patient? Who do you think, when you look at a patient clinically or with a report, who would you say, okay, this one is at high risk for hyperstimulation? Is it obese women? Is it women with high LH? Is it women with high AMH? Which are the patients you get suspicious about for high risk?
Now, we did examine the literature on this. Now, I think it's traditionally thought to be low body weight, but that's probably because the doses of FSH for that volume of distribution were high in the old data. But it is far and away the women with high AMH, polycystic ovarian syndrome, that's the big risk. And youth is a risk. I'm not so convinced that body weight is such a big factor, and I think that's borne out by the data. I'd have to go back to the paper now, I can't quite remember the findings. And I think a past history, obviously, is of significance. And I think there are some quite good algorithms for the calculation of FSH according to body weight and the level of the AMH to reduce the risk. Certainly, the new product marketed by by Ferring. Do you have that in India? Ferring's marketed their recombinant product with that's made from embryonic stem cells. Is that marketed in India? It's called Recovel.
The recombinant FSH?
Yes, recombinant it's from humans as opposed to Chinese hamster ovaries.
No, I'm not aware of that, at least whether it's available in India. But
it has a good algorithm.
Yeah, but the one which which is used, say, on a weekly dose, the alpha polytropin. Do you all use that? The one which is, one dose will cover 7 days.
Oh, yes. Yes, we call that Alonva, don't we? It's corifoliotropin alpha, isn't it? Yes. Look, the trials on that excluded women with PCOS, and I think we should really continue to use the drugs in the selection criteria that they were studied. And I think that using that kind of medication in women with PCOS is really, I think it's a bit risky. So I don't tend to do that, Dura.
Even maybe I'm... No, we don't get it here. We don't get it here, so that's not a question. But the thing is, even if it was, probably I would be very reluctant to use it on a PCO patient. So when you're using your PCO patients, when you're inducing ovulation, I don't think you're getting urinary products there, are you? HMG?
We do. We have the one that we have in Australia is marketed by Ferring. It's Menopur, and so that's from the urine of pregnant women. It is highly purified.
Yeah.
I think equivalent of what used to be called. Oh gosh, it's amazing how you forget the names of them, isn't it? It was called...
No, Pergonal was just urinary HMG.
Yeah.
HP.
HP. Yeah. We only have one now.
When you're doing ovulation induction, you prefer to use just in pure FSH, you prefer pure HMG, purified HMG.
Okay. I think the question is, it's just breaking up a bit, but I think the question is about what preparation for ovulation induction. I think the evidence here is that it doesn't matter. Just use what's available, what's easy and cheap for the patient. I think, I don't think it really matters.
Okay. So there's one of our viewers has asked a question to you. I've had a para 1 PCO patient. She's about 19 years old. Women in our country want to get pregnant at 19.
I wish it's the same in Australia.
Patient underwent IUI twice with CC plus gonadotropin. She's also tried letrozole. She's had good ovulation, no pregnancy, doesn't want an IVF. Will she benefit from ovarian drilling? We don't have any more details on this.
Okay, so we don't know how high her AMH is.
No, this is the question. I don't know what is the AMH. I don't know what's the size of the ovaries. I don't know whether she's obese. So I don't know whether you can comment on this answer.
Yeah, so basically she's had clomiphene citrate combined with FSH, definitely letrozole. And she does, and I think it's very reasonable that she doesn't want to proceed with IVF if we assume that the semen is normal and the tubes are normal. And of course, she's already had a baby, so I think it sounds very reasonable. And so, if she had a high AMH or a high antral follicle count, and she was oligo-ovulatory, I think it's very reasonable to do laparoscopic ovarian drilling on that lady. I think it's very reasonable.
Right. So that she's got your message, I'm sure, what she's asking for. The other question we have is that when you do an IUI cycle, what is the dose you use of gonadotropin? And when you do an IVF cycle, what is the dose? Say for a similar patient, say you've got a patient who's like a normal BMI, and she's got delayed periods, and she's young. What would be the difference in the dose you would use for both the situations?
Yes. Well, if you're wanting to induce ovulation, the starting dose might be 25 to 50. Now, some of these women are very, even though they're very, once they respond, they're very sensitive, they can be quite resistant at low doses. So I also prime them to the story, look, we don't know how you're going to respond. You may need to be patient with me. We may be doing 3 weeks of injections and we may have to cancel. So I sort of prepare them for that because it's a very disheartening kind of journey. But if I was doing that for IVF and I had the same level of AMH and the same youth and so on, then the comparable dose might be 125 to 150 for super ovulation. So, probably, at least 3 times, maybe 3 to 4, maybe 5 times the dose. So you are moving into higher territory, higher doses in order to get that super ovulation. But the truth of the matter is that some women will need 125 or 150 to have ovulation induction. It does vary, and it's particularly in the obese ladies, I think, that they tend to be more resistant to the FSH. But you've just got to take it up slowly. And then once you get a response, if they don't get pregnant from that cycle, then I'm going to do another cycle. I start at the dose at which they previously responded. So that can, so if they started to respond at 125 and I'd gone up 50, 75, 100, and then 125, and they responded at 125, that's where I would start for the second cycle. So the first cycle is a getting to know you cycle, and I do tell them that. And if they're overweight, then you've got that opportunity as you're seeing them each week to see how their diet's going and how their exercise is going, and just function as a bit of a cheerleader. You're doing really well. How shall we pop you on the scales, or will that stress you today? That sort of thing.
A common thing I find with my patients sometimes, only stress on weight loss. So I say, so what? Have you started your exercise? Yes, I have. Then the husband butts in and he says, oh, she started yesterday.
Got to start sometime.
And therefore, then many of them don't want to come with their husbands because the husbands tell the truth, right? Now, I find in your data, in your presentation that you were saying you like to do the estradiol, the progesterone, and the LH values on the day of the trigger, right? Even I like to do that. But there are many, fertility experts who say we don't need to do anything. We just put the ultrasound monitoring, which is good enough. It doesn't really matter if you're not suspecting hyperstimulant. So,
look, I don't need those results on the day. They're not going to change my management on the day, but I do them because if the cycle doesn't work and I'm looking back at what we can do in the subsequent cycle on how to do better, they can be helpful. Yes. And I think, I mean, look, I do really think it's very important if we're ever doing ovulation induction for a frozen embryo transfer. You know, I do see a number of my colleagues not doing this. They do FSH ovulation induction and they don't do bloods on the day that you assume is the pre-ovulatory day. You lock in for that embryo and you could indeed have a mismatch there by not measuring those bloods. So I think it's useful to determine, you know, mainly for the LH deficiency, and to see maybe sometimes I might trigger too early. The follicle might be 16, but then if the estrogen's only 500 and they don't get pregnant, then in the next cycle I might say, well, look, let's just take this one out for an extra couple of days and see if the bloods improve, and depending on how things are going with the convenience of the clinic and so on. But you just like to try things differently in terms of the ovulation induction. It's the sort of the subtleties that get patients pregnant, really, I suppose.
Yeah, absolutely, and that's exactly what I do. And I do find that there are women who have a premature LH surge even before, you know, the follicle is 14. Sometimes you find their LH has gone up, especially the ones with a high basal LH. So those are the women I think it really helps, because then in the next cycle you can avoid that premature surge and help them to get pregnant. So the lady who was asking the question about the previous patient, I told you, whether she's had one child, she's PCOS, and where she was asking whether you would do an ovarian drilling, the same doctor has said that her patient had an AMH of 19. So if the AMH is 19, would you do it?
That sounds low. I have to look at the range. If that's low, then
we measure it with nanograms per ml.
Okay.
Is that very high?
Oh, it's high. Okay. If it's very high, I think it's very reasonable. If it's low, then that would make me think, okay, there's another cause for this woman to not be ovulating, you know, like high prolactin, or there's been a weight shift, or, you know, there's a central component. I need to scan her head. I don't want to miss a pituitary macroadenoma. But if that's high, then yes, these are ideal candidates for laparoscopic ovarian.
Right. Because we measure our readings of AMH in nanograms per ml. And the normal range is approximately till about, the average is about 4 to 5 nanograms in a normal individual. Okay. And with PCOS, maybe we'll find something about 5.5 or 6. There's no defining criteria really, but that's how we measure. So 19 is pretty high for our country, where we have our labs measuring everything in nanograms. So I think we've given her the answer that yes, you would do an ovarian drilling because it would help her. Since she's not wanting to go for IVF and she's not being helped with the routine use of ovulation induction. So then we have another question here, that a woman who's a high risk for hyperstimulation, when you start the gonadotropin, do you start in a step-up sort of protocol, or do you like to start a little higher dose and then come down later? Do you change your strategy depending on whether a patient has, has a high risk for hyperstimulation or not?
Is this for ovulation induction or for IVF?
Yes. No, for ovulation induction.
Okay, I only use step up. I have never used step down, and I'd be very interested to hear if anyone's found it useful. So no, I do step up, and and for IVF I use a fixed dose. But I've never used step down. Have you, Jura?
Not for simple ovulation induction. I prefer a step up, but for an IVF, I would probably use a step down occasionally, because when I want more number of eggs to be growing, I would start with a higher dose earlier. So, but with a simple ovulation induction, no, especially not with a PCO patient. Never. I think we have covered most of the stuff which we wanted to cover. Would you like to add anything more, Claire?
Only to thank you very much for the opportunity to have this lovely discussion. So thank you, and I do hope that it's useful. And I'd be very interested if there's any feedback. If you have any feedback, it would be very good to hear that. Good or bad.
I will send across the feedback to you, and thank you so much for being with us today. It's been a pleasure talking to you, and I'm sure our viewers have benefited from this. We will be archiving the program maybe a week later onto the website of the PCOS Society. Once it's done, I'll write to you and I'll let you know. And,
that's lovely. Thanks, Kira.
Yeah, thank you. And I'd like to announce the next program for what we are going to do. I just want to first acknowledge Monash University and our speaker, Professor Claire, our online delegates, and USV for their logistic support and helping us to take forward these webinars and bringing to you all this information that you've been having. Our next program is set up for the 30th of this month, and we have Roger Hart, who will speak to us on a topic which is what should we expect during pregnancy in PCOS, and are there any precautions we need to take before, during, and after pregnancy in such women. This program will be again shared with you between 2 p.m. and 3:30 p.m. on the 30th of July, Tuesday. Please block your time, block your dates for the next program. And thank you very much for being with us today. We are very happy to have you with us. I'll say a bye-bye to Claire and to you too. Thank you. Bye-bye.
Good night.